welcome to the Community Pharmacist Training Exchange conference call. At this time, I'd like to turn the conference over to Supriya Modi. Please go ahead.
Thank you, Roki. Good afternoon to some and good morning to others. On behalf of the AIDS Education and Training Center's AETC National Resource Center, I would like to welcome you to the training exchange on developing regional approaches to training community pharmacists. My name is Supriya Modi, and I am the program coordinator with the AETC NRC and will be the moderator of this training event. Moving on to slide number 2, each year the AIDS Education and Training Center's National Resource Center coordinates work groups on topics identified through needs assessment activities. For the 2007-2008 grant year, the topic on community pharmacists was selected for an AETC work group. With Edward Dillon from the National Community Pharmacists Association and David Rosen from the New York, New Jersey AETC as our work group leaders, the AETC NRC coordinated the Meeting the Resource Needs of Community Pharmacists work group. Today's presentation was developed by work group members. As you can see on slide number 2, that many people contributed to the development of this presentation. And on slide number 3 lists more work group members. Slide number 4 showcases a guide developed by work group members entitled Developing Regional Approaches to Training Community Pharmacists and AETC Program Coordinators Guide. Based on excerpts of a training guide produced in 2002 by the San Francisco AETC, a local performance site of Pacific AETC, this tool is a collection of HIV pharmacy training recommendations and educational resources. This guide is downloadable from AETC NRC's website, www.aidsetc.org. And in today's presentation, we will go over the main topics covered in this guide. Going on to slide number 5, this slide outlines the format of today's training exchange. Part 1 of this training exchange will be the presentation. We will go over the main topics covered in this guide. Part 2 is our operator-assisted question and answer session. All participant phone lines will be muted until the Q&A session. Should you have any questions after the training exchange is completed, please contact the AETC NRC at info@aidsetc.org, and we will make sure that your question is answered. Moving on to slide number 6, the evaluation component of this program is critical. We use this information to improve our training skills and to ensure continuous quality improvement. Once the training exchange is completed, all registered participants will be receiving an email from me linking to our online evaluation form. On slide number 7, I would now like to take the opportunity to introduce today's presenters. Kirsten Bolano received her PharmD degree from University of California, San Francisco in 1991. Dr. Bolano is a clinical faculty member of the San Francisco Area AIDS Education and Training Center, East Bay AETC, and North Coast AETC, and has been active in training physicians, nurses, pharmacists, and other members of multidisciplinary teams. She's an assistant clinical professor for University of California, San Francisco in the Department of Clinical Pharmacy. Dr. Bolano is also the program director for the new North Bay Advanced Pharmaceutical Program Experiences for the 4th year UCSF pharmacy students. Edward Dillon is a member of the NCPA Steering Committee, the CARE Board of Directors, Cardinal Health Advisory Board, and has served on other national panels. He is an associate professor and lecturer at Howard University and has also lectured at George Washington University. David Rosen is the assistant director for the Division of AIDS Education at the University of Medicine and Dentistry of New Jersey, Center for Continuing and Outreach Education in Newark, New Jersey, where he develops and coordinates needs-based HIV trainings for pharmacists and oral health care providers for the UMDNJ local performance site of the New York, New Jersey AETC. David earned his BS in neurobiology from Cornell University in 1994 and completed his master's degree in social work at Rutgers University in 1996. and their complete bios can be found on the website www.aidsetc.org. I would now like to turn the presentation over to Edward Dillon.
Thank you, Supriya. Good day to everyone, and thank you very much for dialing in and participating in today's training exchange. I'm going to begin my part of the presentation with slide 8, which goes over the 3 basic learning objectives of today's exercise. We want to, first of all, describe successful strategies and alternate methods of developing AETC pharmacy programs. Secondly, we want to offer some practical tips, practical marketing tips for these training programs and how to, get them to the largest possible audience. And our third objective today will be to discuss helpful training tips and resources on the development of pharmacy-specific training programs. With that, we'll move along to our next slide, which is an overview of today's presentation. And we're going to touch on 5 different subjects. Why train pharmacists, which is obviously a question we want to ask, but I think the answer probably is obvious, but we'll go into some of the details. We want to talk about developing AETC training programs for community pharmacists. And again, pharmacists in the community are in a unique position in the sense that they do see patients on a regular basis, but sometimes do not have the clinical tools really needed to do their job adequately. We want to provide you with some helpful training materials that will enable you to develop your program in a way that will be most useful. Next will be marketing strategies. And again, the development of the program, regardless of how well thought out or how well developed the program is, unless we can actually get it out and get pharmacists to participate, really is a non-starter. And then lastly, we'd like to talk about pharmacy continuing education and how to keep pharmacists in the loop with all the current developments in today's marketplace. Our first question, I guess, is why do we want to train pharmacists? And the role of the pharmacist in HIV care has evolved over the years. Today, pharmacists are an integral part of the HIV care team. I would say, though, that unfortunately not all pharmacists are as integrally as involved as they perhaps should be. Also, the ability of different pharmacies and pharmacists to really develop programs and to really interact with patients, we're going to see a very broad difference between the people that specialize in HIV care and those that don't. Pharmacists play a crucial role in educating patients about HIV medications. The introduction of new antiviral drugs the last few years has brought a whole new set of potential pharmacological problems. It's important for pharmacists to educate patients about possible drug interactions and alleviate any fears or misconceptions that patients might have about side effects. Unresolved patient concerns could lead to poor adherence and usually do lead to poor adherence, which may increase the risk of antiretroviral drug resistance, which obviously is a serious global treatment program. Pharmacists should help patients understand HIV therapy goals and help design interventions to enhance adherence, especially for those patients on long-term treatment who may experience pill fatigue. And again, there are a number of unique problems that patients who use large numbers of medications on a regular basis experience. And then ongoing communication with patients also helps foster a trusting relationship between the patient and the pharmacist. We must accept the fact or recognize the fact that the pharmacist probably sees the patient as frequently or more frequently than anyone else in the healthcare team. At least on a monthly basis, when the patient comes in to get their refills, the pharmacist should have the ability to interact with them. In addition, pharmacies tend to be open at least 5 or 6 days a week. No appointments are necessary. So many times the pharmacist is simply the most accessible person for the patient to reach. For that reason, it's important that the pharmacists feel comfortable in dealing with the patients and that they be as skilled in having the information at their fingertips as is possible. Moving on to slide number 12, we're going to talk about the prevention of medication errors, which probably is the single most important function of the pharmacist. We want to make sure that in preventing medication errors, there are at least 3 things, and we can probably expand that. But first of all, communicate with the prescriber to clarify any medication or dosing changes. And also, naturally, make sure that we repeat all of those changes to the patient. And there are several issues here. I mean, first of all, a patient may be seen by several different providers in a clinic. They may receive advice or prescriptions from multiple sources. They may be confused between brand name and generic name drugs. So often when there are changes, patients tend to be confused, and under any circumstances, confusion is clearly going to lead to some type of error. We need to help patients get organized as much as possible, and we can use some very simple aids to do that. Pharmacists should always, and again, to reiterate, should always communicate with the prescriber to clarify any medication or dosing change. Do not assume that, just because it's written that this is exactly correct or that the patient understands it. Constantly referring to the patient profile and making sure that the prescriber is aware of the patient's current dosage schedule is very important. Pharmacists can also help patients prevent medication errors by asking them to repeat dosing instructions. Just because we say it to them does not mean that they understand it. Or quite often it's a very simple thing to do, but ask the patient to repeat back to you how they should take their medication. And then again, with HIV management evolving at a rapid pace, successful training will keep HIV specialty pharmacists and pharmacists who are not specialty HIV providers well informed about the latest advancement in HIV care. I'll now turn the presentation over to Kirsten Bolano. Kirsten?
Thank you, Ed. So what we're going to do next is discuss how to develop the AETC pharmacy training program so that we can enhance the skills that are required to provide HIV care as Ed just described. So let's begin with slide 14. I'm going to briefly just review the various AETC training levels. First, we have, as you know, level 1 trainings, which are didactic presentations. In level 1 trainings, participants are generally passive learners, and these formats would be perhaps panel discussions or didactic lectures. Level 2 trainings are described as skills building workshops, and this is where our learners really have an active participation in the learning process. And this can be done in role plays, case discussions, and some really interesting, innovative, interactive exercises. Level 3 trainings are clinical trainings where we have the learner or the trainee actively involved in clinical care experiences. And these formats are generally preceptorships. Some AETCs will also call them mini residencies. So in this situation, the learners are generally in the clinical setting and working with a mentor who's already equipped with a skill set that we're looking for the learner to achieve. And then level 4 is clinical consultation, and this is where participants can engage in patient-specific clinical consultation. And this is generally a learner-initiated clinical discussion where the learner has a question about a patient that they're caring for and is asking the AETC faculty for advice around a particular case. And then with level 5 trainings, we're providing technical assistance by the AETCs and local performance sites around sort of the concept of capacity building and enhancing overall the delivery of HIV care to our target audience. We can, throughout these various levels, provide some pharmacy-specific trainings. And on slide 16, I will describe what our work group described as some of the pharmacy-specific issues around developing a Level 1 training. So one of the things that's really nice is to introduce the AIDS Education and Training Centers to pharmacists in a Level 1 training. It's been our experience that many pharmacists, and particularly community pharmacists, are unfamiliar with the spectrum of learning opportunities available through the AETCs. So this can be a way to introduce the AETCs to pharmacists and offer them the menu of training opportunities. Again, these are generally lecture-style trainings. They can be standalone events where it's a lecture training for an hour at lunchtime or dinner time or in a grand rounds kind of situation, or we may be sprinkling a Level 1 training within a full day or multi-day event. So the content is not so different than what the training tools have been that the AETCs have developed for other healthcare providers. So we can use the same kind of PowerPoint training materials or other sort of innovative training tools that we've used for physicians and nurses and apply them within community pharmacists. Moving on to slide number 17, here are some of the most common topics that pharmacists have really appreciated within this. They certainly are looking for updates in antiretroviral medications. They're looking at advice around managing adverse reactions and educating patients around side effects. The emerging issues around pharmacokinetics and pharmacogenomics, along with therapeutic drug monitoring, is a very interesting topic to community pharmacists. As Ed mentioned, the issue of medication errors in HIV has been very helpful. And then some of the practical issues around insurance, Medicare Part D, and actual access to HIV medications has also been really helpful topics. Slide 18 gives us a few helpful tips on developing these Level 1 trainings. It's nice, actually, within a Level 1 training to have community pharmacists at programs that also have other professional disciplines, where what you have at a Level 1 training is the spectrum of the healthcare delivery system or the healthcare team, where they can sit side by side and really create the model and the learning environment that will be providing care to patients. It's also wise to connect with local professional pharmacist organizations that can offer CE opportunities for HIV-specific topics. We will be talking a little bit more about pharmacy CEs later in this conference call. Consider, and within that context, using pharmacy-specific CE credits as opposed to just CME credits or other general CE credits does have some advantages, which we will speak to. And then, as I mentioned, sort of with the opportunity to introduce people to the AETCs, to use this as an opportunity to advertise future training opportunities, either what mini residencies are available, what preceptorships are available, and the availability of skills building and clinical case consultation. Moving on to slide number 19, let's talk a little bit about developing Level 2 pharmacy trainings. So here we have the opportunity to provide more interactive learning opportunities, and particularly, in my opinion, around pharmacist-specific trainings. Teaching learners how to utilize information and how to research information in the care of their patients is really quite helpful, because it is virtually impossible for people to learn everything they need to know about the medications used in HIV disease. But what we really want to teach them is how to find the information and then how to critically analyze that information so that they can then provide optimal care to patients. So we can use some really interesting interactive exercises. We can use some internet-based resources to help people develop these kinds of research and analytical skills. And once again, these Level 2 kinds of trainings can be part of a standalone program, can be standalones where you're just doing a 2-hour workshop, or within part of a day-long or multi-day training program. On slide 20, we list some of the common level 2 trainings that our work group came up with. Again, we can use some interactive exercises around the new antiretroviral medications. Adherence counseling is a fantastic kind of skills-building, role-playing workshop. Working through drug-drug interactions is a really great way to try and model utilizing various internet or guideline resources along with managing adverse drug effects. To create some workshops around stigma and cultural competency has been very helpful in training pharmacists. Also having pharmacists really work through what the role of a community pharmacist is in HIV care, and doing that within an interactive exercise has been really very helpful. And even just, kind of backing up and doing some of our HIV 101 case-based skills building around starting antiretroviral therapy and common regimens to start with has been very helpful in training community pharmacists. Slide 21 lists a few helpful tips in developing these level 2 trainings. And once again, if you have pharmacists working through these skills issues with other disciplines, it can really enhance the learning opportunity, where you have the healthcare team problem-solving adherence issues, where the whole team can decide what part of an adherence situation they may take more or less responsibility for around enhancing the care of patients. And how might they communicate those issues to each other is very interesting within a level 2 training. So we have developed some interesting drug interaction workshops and HIV pharmacology workshops. And within the appendix of the guide, we have some outlines and examples of how those workshops might run. What I'd now like to do is turn the presentation over to David Rosen.
Thank you. So if you move on to slide 22, we're going to be now talking about developing level 3 pharmacy-specific trainings. The National Resource Center did a sort of a poll around the country with the regional AETCs to find out who was doing level 3 pharmacy trainings that were specific for pharmacists, and they found an inconsistency across the country. Some regions were doing it using medical preceptorships, some were not doing it at all. So what we wanted to do as a work group is help the regions to figure out how to design these preceptorship modes of training that we know work so well with physicians and nurses and target it for pharmacists. So the level 3 trainings are observational patient-pharmacist contact. So the learner pharmacist would see patient care occurring. And that can be done in 2 areas. Either we're going to be doing it in a clinic setting, or we would be doing it in the community, areas where pharmacists would be having contact with patients. We're going to then describe later on HIV clinical or hospital-based preceptorship design, and then HIV Community Pharmacy-based preceptorship design. And when we say community pharmacy, many of you may think retail pharmacy. Within the pharmacy profession, it has been increasingly they want to get away from the word retail and use community pharmacy in order to emphasize the care component rather than the financial store owner model. And then we're going to talk about how to adapt existing preceptorships that you may have in order to turn them into more pharmacy-focused trainings. If we move on to slide 23, I want to talk about the steps in developing a clinic or hospital-based preceptorship. In New Jersey, since 2004, we've been offering a specific pharmacy preceptorship at various hospital and clinics throughout our state. In order to develop it, what we found worked best here in New Jersey, and this is part of the suggestions for the rest of the regions, is to find a clinic or a hospital-based care site that has a significant number of HIV-infected patients that are seen by physicians or nurse practitioners or PAs. It has a good reputation as being a center for excellence in HIV care. And then here's the trick. Do they have an HIV specialty pharmacist employed to assist them with medical co-management of the patients? This was the dilemma for us in New Jersey because initially back in 2004, only one clinic in the whole state was doing that. Now we have many more, and the trend is for pharmacists to be brought into the care teams. So this may become increasingly easier for other regions to adopt. But we'll also talk later on about what to do if you don't have a pharmacist in a clinic that you can tap for this type of training. If we move on to slide 24, after we've located hopefully a great clinic that has a specialty HIV pharmacist working there, you then need to find out whether that pharmacist is interested in working with you as part of the AETC. There'll be a lot of responsibility placed on that pharmacist in this model because the pharmacist is going to be responsible for ensuring that the training occurs and to provide the direct care opportunities, just like any medical, physician or nurse. Preceptorship has to have their buy-in. You can request a meeting with the pharmacist to discuss whether this is possible. You'd need to look at several key issues when you're having the discussion, such as why do you want to install this program or start this up? What do you think the participants would learn from this, or the key learning objectives? You need to look at operational issues, such as how would people get there? Like, how would you identify participants? How would you structure it? Would it be a half-day, a full day, or multi-day mini residencies, which many regions already offer it for medical providers? Are there any HIPAA concerns? Are there financial compensation concerns? Do you have to pay the clinic for use of their space and time, or do you pay the teachers, the faculty directly? Are there any ACPE issues? Do you want to offer ACPE credits? If you do, then you have to be able to work with an ACPE provider institution. And if you don't, what other options are there? And, pharmacists can use CME, so you may be able to accredit a pharmacy-specific program with CME rather than with ACPE. And then delineate the responsibilities of the LPS program coordinator versus the faculty, and deciding how would you make this work. Would you want people contacting the pharmacist directly for their preceptorship experiences, or being triaged through the LPS? If we move on to slide 25, assuming you've got buy-in from the pharmacist, you now have to get buy-in from the clinic or the hospital. It would be a good idea to meet with the administration, the medical director, and then use the same type of talking points in terms of the purpose of the program, the learning objectives, and the operational issues. And then ask if they have any other concerns or questions that maybe you didn't review or think about when you were working with, discussing things with the pharmacist. The administrator may have some other points that you would need to solve ahead of time to make it operational. If you move on to slide 26, then you have to draft the program details. In doing this, are you offering ACPE or CME? You need to find who the provider is. Fortunately for us in New Jersey, my local performance site offers ACPE, so therefore I didn't have to go far in order to do that. You need to develop an agreement between your LPS and the site. How that's done, you'll have to decide, what the protocols are in your region. A large institution, an academic university, may have a lot of legal hoops to jump in order to be able to make that agreement occur. But if you're if you're a smaller practice or a private medical practice that has an LPS, you may not have those types of restraints. You would need to provide the faculty with learning objectives in order to develop the slide set. Now, the slide set that we use in New Jersey is absolutely shareable. So it was developed by the AETC. It's AETC property. We're right now revising it. So we're hoping by the end of this current year to get it to the NRC for posting. But in the meantime, if people would like the non-finished version especially with all the new meds and the new guidelines, I'd be more than happy to share them with you. Develop an evaluation tool. You would need to pilot test. Now, what we found worked best here was to go, once you have your clinic site, everything is set up, they're agreeing to do it, rather than take a community pharmacist from out in the public who may not have had any contact with that particular clinic or the hospital or your own LPS, we ask the pharmacist at the clinic to identify a friend who's a pharmacist. And we really emphasize friend because what we want is the honesty in the feedback. We want that friend to go through the preceptorship, recognizing this is the first time it's being done, and to be as brutally honest with the pharmacist as they can be about what worked and what didn't work. Because the first time this happens, it may not go smoothly. And I'll talk about that later on when we talk about adapting other programming. But by having somebody that the pharmacist faculty trusts and has a good relationship and a good rapport with, we found it's been very helpful for getting real good feedback and for being able to do the tweaking that's necessary to then launch it for the wider community at large. And so that way you also get a sense that once the public starts doing it, it already has, it's where it needs to be to have a good reputation from the get-go rather than trying to build that reputation over time. You would need to submit the curriculum for accreditation, whether it's CME or ACPE, and that may require a lot of advanced time. So this may not be doable within one grant year. It may take you an entire grant year to just get it ready for launching in the next grant year. We actually had that happen. We started our process in 2003 in order to get it launched in 2004. And the other one, the community-based one, in 2004, we were preparing it for its 2005 launching. And so just to be aware that this may take a multi-year strategy to launch successfully. Moving on to slide 27. Within the preceptorship, common training topics that we've wanted to focus on for the clinic-based was to really look at the pharmacotherapy and drug interactions and the co-management approach. See, for us, this was the unique opportunity to show community pharmacists the value of having a pharmacist working in a care team or with the care team and co-managing patients. Too often, even within their own profession, pharmacists don't feel connected to the medical community. This was an ideal example, because we're showing and demonstrating a pharmacist that does that, works with the physicians and nurses and the PAs. So the learner gets a chance to see that, and we really want that emphasis to occur within the preceptorship. And then to basically do an HIV medical update. Many pharmacists may not even know the basics of HIV disease. They dispense meds. They may know the meds very well. They may know all about the cytochrome P450 system, but they may not know that HIV is a retrovirus. They may not know the simple basic things that we all take for granted. And so this is an opportunity, since there's a physician involved in this preceptorship, to have the physician interact with the learner to give that type of medical information. Moving on to slide 28. So now we have our clinic one up and running. What about the community pharmacy? Can you design something that doesn't take place in a clinic, but actually in the community where most pharmacists are working? For this, it required a little different slants on things. There are many similarities, but there are some differences. Going through the steps, some of the steps are very similar. You have to identify a community pharmacy preceptorship site. Okay, what would that look like? Well, you would need to find a pharmacy that provides a significant number of ARV medications. You need an expert pharmacist that because of the mass volume of scripts that they're sending through their store, they really do have familiarity with HIV medications and disease. But it's not just that. You also have to have one that has a strong reputation within the community as going that extra mile. Do the consumers love the pharmacy, love the pharmacist? Do they feel that they have a rapport? And as an AETC, you can get that through just talking with consumers in the community from the planning councils that you're involved with, either through Part A or Part B. They also need to have a separate consultation room. There's no way that you're going to have adherence counseling going on over the counter. That's going to be in any way meaningful, nor are you going to be able to do a patient observation component if there isn't a private room to be able to really go into the details of medication therapy management, which is really the focus in the community practice. So you need to find this needle in a haystack, and it is possible to find it. We have expanded our program in New Jersey from one site to 4 sites. And it will continue to expand, and it's a slow process. It would be wonderful if I could say every county has one. That's not the case, but 4 is better than none, and 1 is better than none. So if you can think about your own region and how you can find that pharmacy and engage that pharmacist. Moving on to slide 29. Again, it's the same discussion points, but you're doing it with the pharmacy store owner. You need to talk about the patient flow on the training date. That's going to be the most distinctly different aspect. In clinics, you've got large numbers of people who schedule for seeing the doctor on any given day. So you know that you're going to have patients to be able to do the patient observation component. There is no mechanism in place to ensure that the HIV patients are going to pick up their scripts on a particular day. Everyone's cycle is different. People may come at night or on weekends. There may be mail order. They may not even stay or want to stay for further counseling. So you need to be able to figure out a mechanism for ensuring that can happen. In this instance, what we did in New Jersey is have the pharmacist engage with their customers, their patients, and get them to agree to serve as more standardized patients. They're real HIV patients, but they've agreed on a training date that's selected to come in that day for adherence counseling and to pick up scripts if it's near the time when they need to. And that requires just a little finessing that's a little differently. The pharmacies could offer incentives, pay the patients to come in at the set intervals, or offer the patient store coupons or vouchers. But that's going to be the responsibility of the pharmacy, not the LPS. We can't use our LPS dollars for paying patients like that, unless they are serving as faculty, which for the most part they aren't. If you move on to slide 30, if the store owner agrees, you need to draft the program more in detail. It's the same things that you did for the clinic, so we don't need to go over those again. But understanding that the pilot test is the same thing. The store owner should, or the targeted faculty at that store should have someone else that they trust go through it first. You want to, again, get that honest feedback before you open it to the wide community. Moving on to slide 31. The emphasis for training in the community-based one is looking at the drug errors in the retail setting. What types of drug errors are likely to be noticed in terms of faxed scripts or phone calls in or abbreviations, or you can't read the handwriting, those types of errors, or the fact that there may be multiple physicians providing drug-interacting medications with being unaware that each other is doing that, and the pharmacy may be the place that can catch that. Also, over-the-counter products are often purchased at pharmacies, and when they're picking up their script or just on any other day, they may just run into the pharmacy to pick up something, whether it's a diet supplement or it's a vitamin, whatever that is. There may be concerns about how they interact with your HIV meds, and the community pharmacist is the one that hopefully can catch those. And then also the medication counseling through medication therapy management, and that's the focus. The patient observation component is where the learner watches the faculty do actual adherence counseling on the customers in that private room. You can also allow the learner to practice doing that on those patients as well, and that only enhances the opportunity. And that will be a decision based on how comfortable the consumers are in having the learner do the interview. Moving on to slide 32. Now we're going to talk about adapting existing preceptorships, because it's very possible you don't have access to a particular wonderful, high-volume, private room store, or there may not be an ID pharmacist working in a particular clinic in your area. So scenario one, an AETC or LPS without an HIV specialty pharmacist working in a clinic or hospital setting in their geographic region. You can collaborate with another AETC or LPS that does and work a regional cross-AETC approach. Case in point, New Jersey does not have a clinic in South Jersey with an ID pharmacist. So no matter how much I would love to have a clinic-based program operational in South Jersey, I can't. Not the way that I developed them for Central and North Jersey sites. However, Philadelphia, which is right across the river from most of the providers in Southern Jersey, does have an ID pharmacist at clinic in Philadelphia. So what we did was contact the local performance site at the Health Federation of Philadelphia, which is part of the Pennsylvania Mid-Atlantic AETC, and we talked about how we can collaborate. So yesterday, I went down to Philadelphia, and we launched the first piloting of this joint collaborative effort. UMD&J is accrediting the program. Health Federation of Philadelphia is paying the pharmacist, and we're sharing the PIFs. So when a New Jersey pharmacist crosses the river, the New Jersey LPS gets the PIF, and when a Philadelphia or a Pennsylvania pharmacist goes through the program, the Pennsylvania Mid-Atlantic will have the level 3 PIF. And this way, they have the added benefit of not having to try to accredit it, because it's accredited already through New Jersey, and we have access to a clinic that we wouldn't have had otherwise. It's a wonderful opportunity for border states between regions to work collaboratively. We can also connect with HIV clinics with existing medical nursing preceptorships. There is no reason that a pharmacist cannot go through an existing medical or nursing preceptorship. What you would want to do is ensure that the learning needs of pharmacists are addressed within the model. Our suggestion would be for you to take that curriculum and have a faculty pharmacist who's an ID specialist somewhere in the country. And remember, it doesn't need to be in your region. You can contact any of the work group members, but to go over the slide set and suggest where enhancing it with pharmacy-specific topics might be helpful. So you have the ability to do a preceptorship clinic-based even if you don't have an ID pharmacist at the particular clinic. Now, moving on to slide 33, those that don't have a community pharmacy in their geographic region, again, you can contact another AETC LPS. There's no reason, in all honesty, South Jersey has enough pharmacies that it would work, so we don't need to go across the river, but we could. There's no reason we couldn't have worked a similar collaboration with a Philadelphia-based pharmacy and do the same. Or connect with a community pharmacy from, and that's all part of connecting with the other region. So at this point, we've talked about how to adapt the existing preceptorships and how to develop the unique ones specific for pharmacists. And I'd like to turn it over to Kirsten to continue on to level 4.
Okay, thank you, David. So we've spoken about pharmacy-specific trainings in a didactic, passive learning environment, in a skills building, how do I access resources environment, role play, and then specifically around how to provide some practical experiences for pharmacists. And what is also really helpful is once they're in their practice site and they're doing some HIV work, to offer some training that is based on cases they're seeing and questions that they are having, which is what a level 4 training offers. So we can do that in the way that is often modeled with AETCs, where pharmacist providers can call your local or regional faculty or email faculty with questions. But what can also occur within a pharmacy setting is group case discussions. And it is something that we've been doing in San Francisco, particularly with a pharmacy that's serving our Ryan White-funded clinics, where we meet with them quarterly, often in the back of their store after hours, after the store has closed, and they bring their cases and bring their clinical settings to the faculty who are there, and we follow a discussion. And I have to admit that as someone who works in a clinical setting and in an HIV clinic, to see their questions, which are basically, here's the med list. What do we do about this without T-cell counts, without resistance testing, without any other clinical background, is really fascinating to sort of see how they're making some very important clinical judgments with not as much information as is generally available in a clinical site. So to develop such a training, as slide 35 describes, it's really nice. And what we did was in contacting the HIV clinics and asking them, what pharmacies are served by your patients, and then to contact that pharmacy and invite their staff to participate in these case discussions. I think it's really helpful to just have these case discussions be scheduled regularly. Say, okay, we're coming up on our quarterly or monthly case discussion, and to about a week or so ahead of time to consider what would be the topics, or to have them start identifying cases. And if you can identify a key pharmacist within that store that can, motivate and build cases from the staff, it seems to work best. What you can also do, if you have a heads up about the topics and the cases, is the trainers can then actually bring articles or guidelines that will support the discussion. So an example would be, I met with one of the pharmacies I work with just on Tuesday of this week, and for the first time they had some drug interaction cases around some opportunistic infections. And so I was able to bring them the updated OI guidelines from this summer as a resource for them to consider OI guidelines, which after working with them for a year, this was really the first time we were talking about OIs, and I brought those guidelines with me. So again, some of the very common case discussions that have come up in my experience through these level 4 discussions were, when a provider's changing an HIV regimen, especially if there aren't discontinuation orders on old regimens, how does the pharmacist navigate and correct that? Again, the issue of drug errors is commonly coming up around training pharmacists, adherence counseling issues, some of the OTC interactions, and then this concept of, okay, if you've identified an issue in particular around a specific case, how are they then going to go back to the prescriber or to the clinic and communicate some of the issues that came up? Because what will often happen within these case discussions is, because as a faculty member you don't have the T-cell count, you don't have a lot more clinical information about diagnoses, we're not really giving answers about what to do, but we're often providing them with background so that they can talk to the provider in a knowledgeable way around resolving their questions and enhancing patient care. What we also want to point out are just some of the general helpful training materials that are included in this community pharmacist training guide. So slide 38 describes one thing that's laid out in this guidebook is something that we've used in San Francisco, which is kind of the Pharmacist Cafe. And this is based upon a group who's called the World Cafe, where they've done some very interesting research around creating questions and conversations that help to create community and motivate change and just create conversations that matter. So we've used some of their concepts, and as our pharmacists are gathering for either a single day or a multi-day training program, it can be a nice icebreaker, where you can kind of use these resources and questions to open up discussions for forums to share, and start creating little communities and coffee shop style conversations where they can start describing the role of the pharmacist and how important the pharmacist might be and what role they play within the healthcare delivery system. So especially when you're trying to get people to work on level 2 trainings and skills building and role playing, this might be a nice way to start people feeling comfortable with their voice in a learning environment and being an active learner. We also have in this guide some needs assessment surveys, because sometimes the training needs of pharmacists within various local or regional settings may be very different than others' experiences. So you can it's really helpful to begin your pharmacy training program with a survey so that you can learn the needs of your particular audience. So our work group here developed a survey that you may find useful, or that you could use any part of to find out those educational needs of the community pharmacists in your area. The other thing that, as slide 40 describes, is we actually have some, example program agendas, just so that you can kind of see the way that training events for pharmacists have occurred. The program agenda is also a marketing point where you want to have a program agenda that describes and highlights the expertise of the faculties that will help draw participants to the events. We in San Francisco did a lot of work about nearly 10 years ago now with our AIDS Drug Assistance Program, working through needs assessments, and the program agendas from our San Francisco AIDS ETCs really reflect this needs assessment work and has shaped our program agendas. I'm now going to turn the discussion back over to David to discuss marketing strategies.
Thanks. If you move to slide 42, we're going to talk about marketing. I mean, it's all well and good to create these wonderful programs, but if no one shows up, we're not being very effective. So how do we get the message out to the community pharmacists throughout our regions? There are two important factors that the work group has found to be effective. Low-cost CE credits is a magnet for pharmacists. They don't have the access to the type of pharmaceutical companies that do all of these free CMEs for physicians. No one really targets pharmacists, so they have to pay a lot for their CE credits, which they need for their license. So if we can provide free or low-cost CEs, you will get people, banging down the door to come to your programs. Involvement also of key stakeholders in the region. If you can get the leaders in the pharmacy community, and generally speaking, that's going to the pharmacy associations or the colleges of pharmacy in your region, and bringing them in to your planning committees for any programs and trying to use them to market, beyond you. If you move on to slide 43, you can also do direct marketing by identifying the pharmacies. Use the internet. Go to the state boards of pharmacy. Ask Medicaid. Medicaid knows which HIV meds are being prescribed or dispensed all over your state. ADDP or ADAP is a perfect also alternative for finding out which pharmacies. And then contacting the right and right funded medical practices. They know who their patients are going to for their scripts often. Not all the time, but often. If you move on to slide 44, how to reach pharmacists directly. You can contact the various associations and do marketing directly to their email lists or their mailing lists. Target the pharmacists in the local area. Just open up the yellow pages, and you can find where they are and go to them in person. I have found that in New Jersey, it's easier to do face-to-face marketing than it is the mass emails. They get overwhelmed with emails, but they remember a face-to-face visit. And then target pharmacists that might be at other regional conferences that have nothing to do with HIV. Try to set up a booth to highlight your programming. We did that the first year, actually, and it was the New Jersey Pharmacy Association's annual meeting. They didn't have an HIV topic that year, but we got a booth and we put it out there. And guess what? The next year, there was an HIV topic at their conference. So at this point, I'm going to turn it over to Kirsten to go over the continuing pharmacy education issues.
Thank you, David. So we've spoken a bunch about how CE is a draw to get pharmacists into your programs. And as a pharmacist, I can say that pharmacists have to participate in accredited or approved continuing education activities to maintain their licensure. And the hours and what specific kind of CE is required can vary from state to state, and it's each state board of pharmacy that puts the requirements for licensure within that state. At the same time, some of these states will also have requirements for pharmacy technicians to have CE activities. So one of the things that we also really wanted as a work group to highlight is that while we tend to train and target pharmacists, when you're really providing a community pharmacy training, remind yourself that the services delivered by those community pharmacists include the pharmacy technician as well as the clerk staff, and that having everyone from the pharmacy participate in your trainings will be very helpful. So you can include pharmacy technicians as well as the clerks within your activities. One of the best ways in providing continuing education for pharmacists is to really partner up with your state or local pharmacy association. This is where most pharmacists are getting announcements, and they also are generally already accredited to provide the kind of pharmacy education credits that your local state board of pharmacy would require. They're often also just seeking topic speakers, faculty, and other sponsorships. So partnering up with them is often a win-win kind of situation, especially within their annual or semi-annual conferences that do occur. So it's nice to contact them as soon as possible. It's also important to understand that within this group, sometimes the CE application packets, have very specific requirements and can take time, perhaps 45 or 60 days prior notice to get proper accreditation. So it's just good to get some of those details from someone who's been doing this regularly as you're trying to develop your programs. Here on slide 48, we have the websites that are also in the guidebook that actually list the ACPE accredited providers, as well as listing the pharmacy education programs that are offered. I also would like to just mention that around pharmacy CE that some states will allow pharmacists to use CME. California is an example of that, where continuing medical education units, CMEs or CMUs, can be used by pharmacists for their California licensure. I do not know how reliable that kind of information is at every state, but it can be true in some situations. Slide number 49 provides some other just general helpful links that our work group thought would be helpful as you are trying to develop community pharmacy trainings, including the website of the American Association of Colleges of Pharmacy, the Council for Pharmacy Education, Managed Care Pharmacy, and the American Pharmacists Association. Slide 50 is another list of pharmacy associations that you could contact to both get CMEs as well as program information. We also want to point out as a work group that our very own National AIDS HIV/AIDS Clinicians Consultation Center, or the Warm Line, can be very valuable to the community pharmacists. As you know, as many of you probably know, the Warm Line offers HIV clinical information and individualized expert case consultation. It is staffed by healthcare providers, which include pharmacists. So very often when providers are calling the Warm Line, they're often speaking with pharmacists. And so pharmacists in the community, when they have a question about drug interactions or they know that something is something that they should be thinking about, they may sort of know the red flag but not know the answer to it, they can call the Warm Line and ask individualized advice around managing a potential clinical issue. Often those are around drug interaction or dosing questions for a particular patient. At the same time, as slide 52 describes, the perinatal hotline can also be available to community pharmacists. This is available on a 24-hour basis for clinical consultation. Community pharmacists can be involved in the care of infants exposed and need to understand dosing issues or access issues for medications for those perinatally exposed infants and moms. So on slide 53, we wanted to, again, just let you know that what this guidebook has is many helpful links as well as descriptions of developing these pharmacy programs. We've also mentioned, as David has mentioned, that you can collaborate with pharmacy expertise within the AETCs at other regions. In this resource guide, there are lists of pharmacists that are AETC pharmacists that would be available to consult around developing a pharmacy program or a pharmacy training for your area. So in conclusion, on slide 54, our work group just wants to recognize the significant role that pharmacists play within the spectrum of care to HIV-infected patients. And the AIDS ETC's approach for offering various modalities in developing trainings can also be applied when developing pharmacy training programs. We have developed a lot of our programs based upon needs assessment surveys, and this is a great place to start in developing your programs. And we are really hopeful that this guide is going to be a useful tool as you are developing your effective AETC pharmacy training program. So, Supriya?
Yeah, thank you. And now it's time for a question and answer session. We have about 20 minutes for the Q&A, and the presenters would be happy to take any questions the audience may have. Roki, please open the lineup to the audience.
We'll hear our first question from Ann Ricksecker.
Thank you. That was a fabulous presentation, and we all really appreciated it. My question is kind of related to this in the important role of the community pharmacist in adherence, which you talked a lot about. And I'm wondering what thoughts we all have about the increased definitions out of HRSA right now for the Ryan White-funded service categories that are promoting the role of the case managers to be the adherence counselors, and whether there's anyone involved who has done any sort of joint programming between pharmacists and medical case managers within the HRSA system who are supposed to be providing adherence now also.
This is Kirsten, and one of the things that I would comment around that is particularly in our North Coast AIDS Education and Training Center program, we do provide a yearly annual update that has the multidisciplinary team in the program. So we have case managers with pharmacists, with the medical providers, with nursing staff, and various other service delivery providers in our area that are all attending a day-long program around didactic as well as workshop experiences. So it provides an opportunity for them to develop those strategies around co-management. At the same time, I think it's important to recognize that sometimes pharmacists themselves are working in case management situations. The term case manager can mean so many different things across programs, regions, et cetera. You know, there's social work models of case management, there's nursing models of case management, and I would like to point out that there are some pharmacy models of case management, and that within a case manager update, you could acknowledge those three and perhaps have the various providers of the various models of case management service at a program.
In order also to piggyback on that, what we've been doing, because this has been an issue also in Jersey, we've developed training for the medical case managers on adherence counseling with a pharmacist providing the training, recognizing what the community pharmacists' knowledge about adherence and interactions, and we wanted to have that type of communication. On the other side, we then had a social work case manager training pharmacists on doing adherence counseling, which is a topic that many pharmacists don't get much of in their pharmacy school training. We've never thought to put together in the audience the case managers, social workers, and the pharmacists. So, wow, that's a great idea, and I'm going to have to think on that more and see if possibly there's a way to unify our adherence trainings at our TGAs and EMAs to include the community pharmacists within that scope of practice.
And I guess the one last thing I would say about it, and I really appreciate this question, is that one of the things I've recognized in this is that pharmacists in the community don't, when they've found a med error or have a dosing question about a particular patient, one of the skill sets we've developed for them is that if they're having a hard time finding the prescriber, if they're aware that that patient has a case manager, that may be a way to resolve some of their questions or issues. And so that's another way of training the community pharmacists is they don't often recognize the role of the case manager within patient care, and they, kind of go down the tried and true path of I have a prescription question, I'm going to call the provider, where sometimes those prescription questions can be handled through a case manager and sometimes more effectively. So that's one of the skills building techniques that we've used in training pharmacists, is making them aware of the case management services that many HIV patients have.
And I have to say, one of the, yesterday when I was down in Philadelphia, at that particular hospital, University of Pennsylvania, the pharmacists are doing case management.
Right.
So Kristen is absolutely right on with that. I never realized that until I actually saw it happening, where their pharmacists were doing calls about transportation.
Right.
And
benefits and insurance.
Don't you have a social worker to do that?
Yeah.
And they said, yeah, but if we waited for the social worker, because there's one for 1,000 patients, it wouldn't happen. So the pharmacists were picking up a lot of the slack on that.
Those are fabulous ideas. Thank you.
Ms. Modi, there are no further questions at this time.
Okay. Now, during registration, participants had a couple questions. So I'll begin with Kirsten. How do we prioritize which pharmacists are most important to train?
Yeah, that is a great question in terms of prioritizing the pharmacists. And, I think that there's a couple of different priorities based upon a region. If we take just the concept of clinic-based pharmacists, we briefly touched on it with David's description of level 3 preceptorships within a HIV clinic. But I think that to prioritize training HIV pharmacists that could be part of a clinic, I think is really helpful, because that is a very successful model for delivering quality HIV care, is to have the pharmacist in the clinic. And so that may be one of the priorities if your region doesn't have a clinic-based HIV specialty pharmacist. In terms of the community pharmacists, and how do you identify those community pharmacies or community pharmacists to prioritize? Again, I would really urge you to go to the clinics that are being served by your Ryan White funded patients or your target patient population and ask them, where are these patients getting their medicines? What pharmacies are serving our patients? And that would be where I would really target my outreach and survey needs assessment efforts.
Just to piggyback, I would also recommend going to Medicaid and ADAP, because they have the records as to who is dispensing those HIV meds in large volumes. And the large volume pharmacies, which may not be associated with a Ryan White clinic for whatever reason, it may be a Medicaid FQHC, those pharmacies that are doing the high volume are absolutely essential targets.
Thank you. And there was another question that the registrant had, was what are other cutting-edge practices doing with clinical pharmacy services? So, Kirsten, do you have any insight to that?
Yeah, well, we've mentioned about pharmacy case management, where the pharmacist, either in a clinical setting or perhaps even in a community setting, is doing some ongoing case management type of efforts. I think the other thing that is happening, particularly in a community pharmacy setting, is that some pharmacies are really specializing in HIV care, where that is the majority of the patients that they are serving. And they may have some particular training needs that would be different from the more typical chain store or other independent stores that aren't actually specializing in HIV. And some of the specialty pharmacies, as well as others, are providing some of the actual tools that we talked about. They are filling medisets for patients and delivering them to them, or they are sometimes even having herbalists or acupuncture in their stores to provide a continuum of HIV-related services within their store and their setting. There are also some clinic-based pharmacists that are doing some very interesting work, around adherence, certainly, but sometimes also around therapeutic drug monitoring, pharmacogenomics, pharmacokinetic studies. So there's a lot that's happening within the profession of pharmacy. The other thing I think I'd like to mention is that the American Academy of HIV Medicine has also opened up their HIV specialty exam to pharmacists, where pharmacists can register to take the exam and get certified as an HIV specialist. And that's something that a number of my colleagues have been working on, and I think I will be registering next year for that. And one of the training opportunities is maybe to even provide some study halls in some ways around that exam for pharmacists in your area that might be interested in becoming certified as an HIV specialist. And I think that there are some other exams that are available. David, I'm not sure if you can comment on them, but I am probably familiar with the AAHIVM.
Yeah, just that certification exam, just to be aware, right now there's controversy about it because they're not opening it up to bachelor-level pharmacists.
So it's PharmDs.
That's PharmDs, and there is an uproar because while it's true that all the pharmacy schools are only graduating PharmDs now, there is, 50 years of bachelor level pharmacists working in the community right now.
But the fact that they opened it up is a good first step.
Yeah, but just to be aware that when you start telling people about it, they know they have to expand it to the bachelor level. They haven't yet. So just to give the people who are bachelor level that knowledge, that information, so they don't try to sign up and then be denied it. In terms of any other certification, we really haven't seen anything specific to pharmacists aside from the Infectious Disease Society of Pharmacists, right? They have, but that's not just HIV specific.
Yeah.
And then
the board certified pharmacy specialists and ID.
Yeah, so that's definitely an option, but it's not specific to HIV. One thing that I do know that they're working towards, medication therapy management as a reimbursable service for pharmacists to get them away from being paid only by the pills they dispense, but instead to be paid for providing consultation services and adherence counseling services to patients. We're running a study in New Jersey with the Pennsylvania Mid-Atlantic AETC and the New York, New Jersey AETC to hopefully demonstrate that if they do pay the pharmacists to do that, MTM, there'll be better health outcomes. We're not going to have results for another year, year and a half, but the idea is if you start building your program now for pharmacists, and if this is successful and Medicaid and ADAP decide and private insurance to pay pharmacists, but only if they're certified, it may be a golden opportunity for your AETC over that.
Roki, were there any other questions from participants?
No questions over the phone line at this time.
Okay, then I would like to go with the final question of the day. Somebody had asked if there are any PowerPoint slide presentations you have available that are targeted to pharmacists. So, Kristen, I'll begin with you if you have any PowerPoint slides.
Well, I mean, one of the things that I would like to point out is that this particular guidebook has some really nice workshop exercises. And, one of the strategies our AIDS ETC has taken on is really trying to create those skills-building exercises and role-playing in workshops. So while PowerPoint slides are great and convenient for many learners, I do want to point out that, the skills building and the case-based exercises, we have some examples in this guidebook and can really be very useful in training pharmacists. We have put together some medication error talks. I think that, a lot of the slide-based talks that are on the NRC website cover many of the issues that we talked about that are useful topics for pharmacists. It covers, some HIV medication overviews. They cover some of the updates and novel therapies. There are some PowerPoint slides that talk about adherence. So, doesn't have to necessarily be recreating the wheel for a pharmacist. You can take the topics that you have and just, have the pharmacist in the audience. You don't necessarily need to change your PowerPoint talk for pharmacists as much as just getting them in the room and acknowledging their importance to the team.
I would recommend also, if you have a pharmacist faculty in your region that you trust, or you want to access one of the ones that are listed in the guidebook, you can send them a slide set that you have that you used for medical and nursing providers, and just have them just review it and see what they might suggest adding or changing to match better with a pharmacy audience. The final thought I would have as well is just to be aware that the meds change so much and so quickly that it's going to be outdated. Any pharmacist-specific slide set that talks about meds is going to be outdated within 6 months to a year.
Which is why I came up with a bunch of interactive
Exactly. we struggle with this as a work group. We actually decided that we weren't going to create PowerPoint slide sets for people because we knew it would be, by the time it got published, the guidelines would have changed.
Roki, are there any other questions from the participants?
Not at this time.
Okay, so as our hour is up, on behalf of AETC NRC, I would like to thank our speakers, Ed, Kristen, and David, for a wonderful presentation today. And thank you very much to all our work group members to help make this presentation, training event, and the guidebook possible. Thank you to all our participants, and have a great day. Thank you, everybody.